and first and second part of duodenum. Remember, duodenum has 4 parts, right? So the first and second part of duodenum come from foregut, okay? And that's the structure. So totally esophagus, stomach, first and second part of the duodenum. They all came from foregut. So foregut gave rise to all those structures. Now moving to midgut, third and fourth part of duodenum, jejunum, ileum, cecum, and ascending colon, and proximal 2/3 of transverse colon. They all came from midgut. Okay. That's that. So third and fourth part of duodenum, jejunum, ileum, cecum, ascending colon, and proximal 2/3 of transverse colon. Is that clear, folks? Okay. Now, going to hindgut is your distal 1/3 of transverse colon, descending colon, sigmoid colon, rectum, and anus. All this comes from hindgut. Those are the GI tract. I did not include any organs, okay? These are GI tract. Now, if I were to go back to the GI organ, your liver, gallbladder, pancreas, and spleen, they all come from foregut, okay? All the GI organ, it came from foregut, folks, okay? That's important. Now, liver, gallbladder, pancreas, then you should be wondering spleen. Spleen has nothing to do with the GI, but it came from foregut, so it has to be part of foregut, folks, okay? So spleen is part of it. Now, I'm missing one structure. Anybody? You could type it, don't say it. What structure am I missing here? I'm missing a very important structure here. Appendix. Do you guys think about it? Appendix belongs to midgut, okay? Now, why appendix belong to midgut? Because appendix is direct extension from cecum. Does that make sense, folks? It's part of the cecum, right? It comes. Now, appendix is kind of in the middle. It's not 100% classified as an organ, also not classified as a GI tract, but still it belongs to midgut, folks, okay? So this structure, foregut, midgut, hindgut, this has to be in your memory in fingertip. If you close your eye, this picture should come in front of it, because that's very important, because we're going to talk about more anatomy, right? Now, why do we need to remember this? If I tell you, so let's say if I'm asking what blood vessel or what artery supplies stomach or first or second part of the duodenum or any of the organs, the easy way to say, all the foregut structure get oxygenated blood from celiac artery. We call celiac trunk. Okay, so celiac trunk give oxygenated blood to all these structures. Of course, they have their own branch. Okay, celiac trunk is a big branch, but that comes and divided into small artery to duodenum, small artery to stomach. And we're going to talk about this, but at least you know the main branch is from celiac trunk. Is everybody clear, folks? Same thing with the midgut. It's going to be superior mesenteric artery. Okay, it's going to be superior mesenteric artery. So you might not know the exact branch of appendix, but if I ask you who supply appendix, at least it's a branch from superior mesenteric artery. Is that clear, folks? So all the midgut structures get oxygenated blood from superior mesenteric. Same rule we're going to apply to hindgut, inferior mesenteric artery. Inferior mesenteric artery, folks. Okay, so that's very important.
Doctor, what is that word, the second to last word? They have sigmoid colon.
Rectum and anus.
Oh, thank you.
Okay. I specifically wrote because a lot of textbooks stop with the rectum, but we should know there's a small part after that. Is anus is completely different, but it's also belong to hindgut, folks. Okay, so that is your SMA and IMA. Now going back with the venous drainage. So now we know the arterial supply. So you need to know the venous drainage. Venous drainage becomes a little easy. The same name. Hindgut get drained by inferior mesenteric vein. So if you have inferior mesenteric artery, then you have inferior mesenteric vein. Same thing for midgut, superior mesenteric vein. Okay, superior mesenteric vein. Now go back to foregut. Do we have a celiac vein? Yes or no? There is no celiac vein. Okay, so instead of celiac vein, I'm going to write this. This is very special. Inferior vena cava, IVC. Okay, that's very important. All your foregut get drained by the blood vessel called IVC. Okay, that's an exception because next thing we're going to talk about portal vein, and you should know IVC is a part of systemic blood vessel. They are not part of portal vein. Okay, now I will do the portal vein, then it will make sense. I'll come to that. Okay, but that's a arterial supply and venous drainage. Now, those are the three structures for gut, midgut, and hindgut. Now, you could apply the same thing with lymphatics, right? If I ask you which lymph node drains, you could say celiac node for foregut, superior mesenteric node for midgut, and inferior mesenteric node for hindgut. You see, when you know this chart, it makes your embryology and anatomy is so easy. Is everybody clear, folks? So that chart needs to be memorized first. That's your first task when it comes to GI. Is everybody clear? Go ahead and copy this.
What is after? Oh, that gilium, right? Gillium?
Which one?
Before ilium. Before ilium is
jejunum.
gillium, right?
Jejunum.
Right, okay.
So make sure when you go to sleep tonight, if you close your eye, this page should come in front of you. Okay, that's important, folks. It will help you a lot of time when you do questions. Okay, so that's this part. Any question in here? No? Okay. With this information, I'm going to go start. They have some embryological diseases. We'll come to disease later. First, anatomy. Go to the page 369. First, we're going to talk about retroperitoneal structure. Now, to learn retroperitoneal structure, let me do a lateral view of GI tract. So this is just to understand. You don't have to really draw it, but okay. So this is a posterior surface, posterior back, and this is your anterior surface. That means somebody's looking at me on the side, okay? So this is your anterior abdominal wall, and this is your back where you have your vertebral bone, okay? We did a similar drawing for respiratory to see the mediastinum, if you remember, folks, okay? So I'm gonna tell there's a diaphragm right here, right? So that's your diaphragm. Now this is your abdominal cavity, okay? So this is your abdominal cavity. Now, inside the abdominal cavity, there is a layer, okay? So it starts from the back, it can come and it contains so many things, and then it goes back like that, okay? We call this peritoneum, okay? We have a parietal peritoneum and visceral peritoneum. But if you see here, peritoneum, it's like a bag inside the abdominal cavity. So we have some organs inside the peritoneum. That means the organ is fully covered by peritoneum. Is everybody clear, folks? So if you see the organ is fully covered by peritoneum, we call that intraperitoneal organs. That means that organ is fully covered by peritoneal layers. Now, if you go here, I'm putting this black X. You see that? They are covered by peritoneum only in the anterior part. In the back, there is no covering. Is everybody clear, folks? We call this retroperitoneal structure. Retroperitoneal structure means these are the structure that's located behind the peritoneum. Is everybody clear, folks? So retroperitoneum means they are located behind the peritoneum. So if I ask you, is retroperitoneal structures are covered completely by peritoneum? The answer is no, they are not. Everybody clear? So that's important. These are retroperitoneal structure that's located in the back. Now, why do we need to really know that? Now, if you see the book, look at this. Adrenal gland, okay, and the aorta and IVC, duodenum, from the second, third, and fourth part, not the first part. Then you have a pancreas, ureter, colon, all these things, right? I'm going to highlight some of them. Now, what I highlight, these are most important. Why do we need to learn retroperitoneal structure? The answer is the presentation of pain. Any retroperitoneal structures have a disease or inflammation, the pain is always in the back. You never get the pain in the front, okay? It's always in the back. Let's take a good example, pancreatitis. When patient has acute pancreatitis, how do they describe the pain? Epigastric pain radiating to back, isn't it? So the pain starts in the front. We call it a referring pain. So that means in the beginning it's in the front, but eventually it goes to the back because pancreas is located in the back. Second example, when people have aortic dissection, what is the pain? Epigastric tearing pain radiating to back because aorta is also located in the back. So the pain has to move to back. When people have a kidney stone, how do they explain? They have a costovertebral angle tenderness or the pain in the back, isn't it, folks? And radiating. So whenever you have a diseases or inflammation of the retroperitoneal structure, the pain is always in the back. So when you read a question, if the question says pain radiating to back, you should know it's a pathology of a retroperitoneal organ. Is that clear, folks? So that's retroperitoneal structure. That's the only reason that you need to understand this. So are we clear with what is this retroperitoneal structures?
So the peritoneum is over the abdominal cavity?
They are inside the abdominal cavity, covering some structure completely, and some of them are not.
And
so if you have to do a surgery, let's say if I have to do an incision here, I have to cut the abdominal wall, and then I also have to cut the peritoneum to get into these structures. So actual abdominal cavity, when we call it peritoneal cavity, these are inside. Is that clear, folks? So that's the covering, okay? Now, if you see the book, they have this picture, right? Now, look at this. This is that peritoneal layer. So everything here is intraperitoneum. Only whatever is in here, those are retroperitoneum. Is that clear, folks? Okay, but I don't like this picture. I like the lateral view so you see it properly. But all the retroperitoneal structure, pain radiating to back. Are we good with that, folks? Okay. Now, it's good if you can memorize all this organ, but at least you should definitely know what I highlighted here, folks, because most of the pathology comes from there. Okay, so that's that. Now, some ligaments, folks, this page. The first three ligaments are super high yield because there's a lot of pathology and clinical correlation can be done. Let's talk about these ligaments. When you learn about these ligaments, what do you need to learn? First, ligaments are structure. It supports to hold the organs here. If you see the first one, falciform ligament. What that falciform ligament does, it connects the liver to the anterior abdominal wall. Now think about, folks, your liver is in the abdominal cavity. It's staying against the gravity, isn't it, folks? It doesn't come down. Why it doesn't come down? Because falciform ligament is holding it. That's why it doesn't come down. So that's why it's connect the liver to the anterior abdominal wall. You could see that that's the structure. Falciform ligament is in the middle of the liver, separating two lobes. Okay, so that's falciform ligament. So the first objective is to learn what does it do. The next thing to learn, what do we have inside? Now this is important. This falciform ligament is keeping another ligament inside, what we call ligamentum teres heparis. So if I cut and open the falciform ligament, I see another ligament inside. So it's like one ligament is holding another ligament. Is that clear, folks? So that's called ligamentum teres heparis. Okay, this is super high yield because exam can ask, what does ligamentum teres heparis do during embryological period? This was your fetal umbilical vein. So once embryology, fertilization happened, you have umbilical vein, right? Umbilical vein and umbilical artery. Umbilical vein is one of the good example where it's called vein, but they carry oxygenated blood. Once the baby is born, right, the fetus is born, you don't need umbilical vein. So what happened? This umbilical vein obliterates. It's basically dries up. When it's obliterate, it becomes a ligament. We call ligamentum teres heparis, and they are hidden inside falciform ligament. So sometime in the exam, they could ask you, what is the remnant or what does it ligament teres consist of? It's umbilical vein. Students have a tendency to pick umbilical artery because we think artery is important. I understand, but very careful. When it comes to placenta, vein is more important than the artery. Is everybody clear, folks? So that's a first ligament. Okay, so that's ligamentum teres heparis. If you know this much, there's nothing else to learn in falciform ligament. Okay, so we know what it holds inside and what was that during embryological period. Next, hepatoduodenal ligament. In Latin, folks, see, most of the medical terminology came from Latin and Greek, right? What they say, you could join two organs or two structure just by adding a letter O in the middle. That's one of the nomenclature of Latin, right? Look at the word hepatoduodenal ligament. We call hepatosplenomegaly, right? We heard that terminology before. So hepatoduodenal ligament means simply that word says it connects the liver to the duodenum. It connects the liver to the duodenum, folks. Okay. Now in this picture, this is your hepatoduodenal ligament, but I don't like that. That's not the great picture. But let me pull up another structure. The structure hepatoduodenal ligament is very important to understand it. So let's go back and take a look. Let's see. Now, if you see, let's say here, you see here, this is the liver, right? This is the liver, and this is the duodenum, the first part of the duodenum. There's a ligament that connecting. Can you guys see that? That is your hepatoduodenal ligament. Now, in here also, it's a small picture. Let me see. Okay, look at that one. You see that? This is the liver, and there's a ligament that comes to the duodenum part. That's your hepatoduodenal ligament, folks. They cut it open for you to see. But first thing to learn where exactly it's connected. That's hepatoduodenal ligament. Okay, it's connecting the liver to the duodenum. Now, this is very important because inside there's about 3 structures. That is the very important to keep an eye on. That's 3 structure. Now, if you go in there, let's go back to the book. Now, if you see here, inside of that ligament, you have something called portal triad. When you say portal triad, that's a 3 structure. It consists hepatic artery. So it consists of artery, portal vein, and common bile duct. You see that, folks? Very important. 1, 2, 3. So hepatic artery, portal vein, and bile duct. All those three structures are inside of this ligament, hepatoduodenal ligament. So during surgery, especially when they want to remove gallbladder, right, we call cholecystectomy or anything, the surgeon has to be extremely careful not to cut that ligament, because if they cut the hepatoduodenal ligament, technically they are cutting all those three structures. Is that clear, folks? That become a massive complication after that. So they are very careful with that, okay? So that's the portal triad, three structures that's inside, folks. Is everybody clear? All right. Now, there is something called Pringle maneuver. You need to know this for your step 1 exam, folks, okay? This is the key. Now, let me add the three structures, okay? Now, we have a hepatic artery. This is important, folks, okay? You're not going to learn anywhere else. And you have a portal vein. And I'm going to write something else here, inferior vena cava. These three structures are in a similar region. So in another word, if I cut the hepatoduodenal ligament way behind, you have inferior vena cava. Is that clear, folks? So those three structures are in similar location. During surgery, sometimes it's very easy to damage one of those three structures. When we damage, what's going to happen? Patient is going to bleed a lot in the abdominal cavity because we just cut one of the blood vessels. Is that clear, folks? When we cut that and patient is bleeding, first thing the surgeon wants to do is find out where we're bleeding from, right? We need to know where we are bleeding from. So what they do, there's a small foramen called omental foramen, okay? So it's like a small hole in that region we could put our finger. When we put a finger, what that finger does, the finger goes and compresses these two structures. The finger compresses hepatic artery and portal vein. The finger compresses hepatic artery and portal vein. I repeat one more time. When I put my finger in the omental foramen, okay? And another word for omental foramen is called epiploic foramen, if you heard that name, okay? Foramen of epiploicum. If I put my finger in there, I'm literally compressing hepatic artery and portal vein. Is everybody clear, folks? So what we do in a Pringle maneuver, the patient is bleeding, I need to find out where they are bleeding from. So what I do, I put my finger in the omental foramen. As soon as I put the finger, if the bleeding stops, that means they are bleeding from one of these two structures. Is that clear, folks? As soon as I put the finger, if the bleeding stops, they are bleeding from either hepatic artery or portal vein. If I put the finger and still they are bleeding, that means they are bleeding from IVC. Because why? When I put the finger, I'm compressing only hepatic artery and portal vein. I'm not compressing IVC. Is that clear, folks? Now, that process, that Pringle maneuver, is to differentiate whether you are bleeding from hepatic artery or portal vein versus IVC. Is that clear, folks? That's the only way to differentiate. Now, I know you might have a question, how do we differentiate hepatic artery versus portal vein within that structure, right? I'll come to that. Go ahead, Alize. What's the question?
So my question was, you said where you put your finger to control the bleeding. That location, is it the one that you showed us, like the circle part?
No, that circle part is...
I'm trying to figure out.
No, that circle part is literally cut on the picture I showed you. This is an omental foramen. Let me see if I can show you here.
Thank you.
Let's see. So this is not the best picture, but this is what I can find now, okay? Now, if you see here, this is the hepatoduodenal ligament, and you see how they are putting the finger in there, right? And it's kind of hard in this picture, but omental foramen is a structure in the human body. The picture I showed you before, it's somebody cut that ligament. If you cut it, how it looks inside. But the omental foramen is right next to the liver some here, folks. Okay, let's see if I can find another picture in here.
So, omentum foramen is above the ligament, or is it
It's next to the ligament site next to it. So
okay.
put it in a way, if you put the finger, it goes into those two structures that I explained. Okay. So that's where that goes to. So the bottom line, what you need to know, when we do Pringle maneuver, it's separating the bleeding from hepatic artery and portal vein from IVC. Is everybody clear, folks?
So
Okay.
it's
Now-
different. So basically, it's different from foramen of Winslow.
It's the same thing. The one you say, foramen Winslow, is an English name for the same ectoploid foramen.
Okay.
Okay. So let's do a question in this topic and let's see what we can find. Okay, let me pull that up here. All right. Read the question and send me the answer. Now you see, for this question, you could read the whole question, or you could actually read the last one line and get the answer, isn't it, folks? Right? So, but you know, what we learned, we should always read the whole question, okay? 23-year-old man is brought to the emergency department after he was stabbed in the right upper quadrant of the abdomen. His blood pressure is low. See, the minute you see a low blood pressure, that tells you they are bleeding, okay? Now, physical examination shows a stab wound 2 centimeters inferior to the right costal margin, and the patient's abdomen is firm and distended, so they are bleeding in the abdominal cavity. There's a test called FAST, basically focus assessment of sonography. Is it positive for blood in the right upper quadrant? So we already know the patient is bleeding inside the abdominal cavity 100%. He is taken for immediate laparotomy, and approximately 1 liter of blood is evacuated from the peritoneal cavity. So that's a lot of blood. Brisk, non-pulsatile bleeding is seen in the behind the liver. So they are bleeding behind the liver. So that could be hepatic artery, portal vein, or inferior vena cava. Does everybody agree? Okay. Now, the surgeon occludes the hepatoduodenal ligament, which means the surgeon is doing the Pringle maneuver. Is that clear, folks? And they said the patient continued to bleed, continued to hemorrhage. So that means I should know it's not hepatic artery and it's not portal vein. Is everybody clear, folks? If I compress and the patient is still bleeding, that means it's not those two. So then the answer must be inferior vena cava. Is everybody clear, folks? So that's important, okay? See, that's your Pringle maneuver. Is everybody clear, folks? If I change this question, so careful, listen to me carefully. What if I tell you, once I occlude the ligament, the bleeding stops? What's the answer then? Type it up. You can't give me 2 answers. I need 1 answer. So if the bleeding stops, what I taught you so far, it's hepatic artery or portal vein, isn't it, folks? But can you tell me 1 answer? You know, your answer has to be either C or E, isn't it, folks? How do you differentiate? Don't tell me Dr. Roy didn't teach. I don't have to teach. It's in your answer. The answer is portal vein. Why not hepatic artery? Whoever picked C, if it is hepatic artery, that should be pulsatile, not non-pulsatile. Only venous blood doesn't have pulse. Arterial blood has pulse. Is that clear, folks? So that's the only word. If I change this word to pulsatile bleeding, then you could go for C. You see, 3 concepts you could learn in this question. It's not only Pringle maneuver, also to differentiate hepatic artery from portal vein, how to do that. Is everybody clear, folks? All right, so that's that question. 10583, okay. All right, so let's go back. So that's Pringle maneuver, folks. Okay, so make sure you guys know that pulse word. Okay, so that's hepatoduodenal ligament. Are we clear with that? All right, so next, hepatogastric ligament. Look at the word hepato. That means it's liver. Gastric, gastric means stomach. So it's connecting the liver to the stomach. Okay, liver to the stomach. Now, if you take the liver to the stomach, right? So let's say the stomach picture. So if I were to just draw, this is the stomach, okay? Imagine. These are called laser curvature or minor curvature, and these are called greater curvature. Is that clear, folks? So that's a laser curvature. So that means, this is a schematic diagram. You have a liver somewhere here. So there's going to be a ligament that's connecting here, folks. Is that clear, folks? That's going to be hepatogastric ligament. Now, if I tell you I have a ligament that connects here, that should be hepatoduodenum because it's connecting liver to the duodenum. Okay, so this is hepatogastric ligament. It connects the liver to the laser curvature of the stomach. It has gastric blood vessels, folks, okay? It has gastric arteries. We're going to go more deep into each individual branch in the next page, but we should know laser curvature has a lot of gastric arteries. Now, why do we need to know laser curvature, folks? I'm just putting this X around the laser curvature. When patients get gastric ulcer, laser curvature is the most common area to be involved, okay? Now, this is the big picture. Again, I'm talking about peptic ulcer here. Everybody knows what's peptic ulcer. Peptic ulcer has 2 types. One is called gastric ulcer, other one is called duodenal ulcer, isn't it, folks? The gastric ulcer happens in the stomach. Duodenal ulcer happens in the duodenum. But stomach is a big structure. If I ask you where does it more commonly happen, it's in the laser curvature. Is that clear, folks? It happens in the laser curvature. We'll talk about that more, but I'm telling the importance of knowing laser curvature and structure around it, okay? So that's hepatogastric ligament. Is everybody clear, folks? Now, these 3 structures are very important. You cannot forget these. Now, if you look at the other 3, folks, okay? Look at the word gastrocolic ligament. That means it's connect the greater curvature of the stomach to the transverse colon. In my drawing, if the transverse colon is somewhere here, okay, that means there's a ligament that connects the greater curvature. Is everybody clear, folks? So that's your gastrocolic ligament. Not much to learn here, and there's not much of clinical history also. So that's gastrocolic ligament. Gastrosplenic ligament, greater curvature to the spleen. So that will be somewhere here. You have a spleen here. So I might have a ligament that goes to the spleen. So we call that gastrosplenic ligament. Okay. Now, gastrosplenic ligament, I would probably say you should know this short gastric arteries are there. I'm going to cover that in the next page. Okay. That's gastrosplenic. And the last one, splenorenal. It connects the spleen to the kidney, folks, not clinically important. Now, the first 3, and possibly, let me highlight this gastrosplenic just to be on the safe side. That 4 ligament, if you are getting a question on this page, which you will on the exam, it has to be one of those 4, 100%. You cannot get it in anywhere else, folks, okay? So that's the idea here. Now, any question in these 4 ligaments? All good? All right, so we are doing anatomy. I know some of the question you might have, it's like putting a puzzles together. So by the time we finish, it will make sense, folks, okay? Now, once we are done with that section, I actually want to go to this page because they're in a different order. I want to go to the page 372. Now, if you see the right next to 372, there's a small chart. I wanted to take a look at it. You see here, foregut, midgut, hindgut. I did similar drawing to this, but this is a similar, but the one I did has a little bit more information. You already know foregut, midgut structure, what artery supplies. Here they didn't put vein and we already added the vein. Is everybody clear, folks? Now, I wouldn't be worried about the nerve innervation because all the GI tract is predominant by parasympathetic nerve, right? We know that. So it has to be a vagal nerve. Vagal nerve is the only cranial nerve that runs all the way to the abdominal cavity. There's nothing else, folks, okay? So not to worry. So this is the chart that we almost draw on the embryological section. Is everybody clear, folks? Okay. Now, let's go to this picture. See the aorta, right? The aorta is basically the biggest blood vessel in the human body. It comes out of the heart. We have ascending aorta, arch of aorta, and then we have descending aorta. The descending aorta is divided into thoracic and abdominal aorta. So here we are talking about abdominal aorta. So when do we call it abdominal aorta? Once it comes below the diaphragm. Is that clear, folks? So in respiratory, we studied at what level it perforates the diaphragm, right? So that's perforates and comes into the abdominal cavity. Now, if it comes to abdominal cavity, aorta has so many branches, but I want you guys to pay attention to these three branches: celiac, SMA, and IMA. What do you see special in here? These are the only three branches that comes actually anteriorly. You see that? Everything else coming laterally. Everything comes on the side, but these three branches are coming anteriorly. Is everybody clear, folks? So that has a lot of clinical correlation, right? It could be useful or it could be problematic. So that's what we're going to do. So celiac, SMA, and IMA, folks. Now, if you see here, first, I'm going to talk about superior mesenteric artery syndrome, folks, okay? Now, let's take a look at here. So what happens here? This is your SMA. So I'm going to write, this is normal. That's physiology or anatomy. That's normal. So you have a duodenum, aorta, duodenum, and then you have a superior mesenteric artery, and there's a fat in here, folks, okay? Now, in between the superior mesenteric artery and the duodenum, there's a fat, okay? So your superior mesenteric artery is sitting on top of the fat. Is everybody clear, folks? So superior mesenteric artery. So again, the order from, see, superior mesenteric artery, fat, duodenum, and then abdominal aorta. That's the order. Is everybody clear, folks? So sometimes what happens when people lose weight, when they lose weight dramatically, they lose so much of weight, they also lose the fat in this area. When the fat is lost, you see the angle of superior mesenteric artery, how it has changed here. So now they are literally sitting on top of duodenum. Does that make sense, folks? They are sitting on top of duodenum. That's fine. It doesn't do anything. But when a person eats, so we eat, the food goes to the stomach, and after about few hours, the food is moving from the stomach to the duodenum. Does that make sense, folks? We call that time postprandial. Postprandial means after eating. Now the duodenum is going to enlarge. Why the duodenum is enlarging? The food is coming in. Does that make sense, folks? Now when the duodenum tries to enlarge, the superior mesenteric artery would not allow because it's going to compress that area. Is that clear, folks? That is called superior mesenteric artery syndrome. Superior mesenteric artery syndrome is defined as where SMA is compressing the duodenum. Simple. Is that clear, folks? Now, when does it specifically happen? Intestinal obstruction symptom, primarily postprandial pain. That means it only gives the pain symptoms only when people eat, after eating. Postprandial. If they don't eat, they don't see the symptom. Why? If they don't eat, duodenum doesn't have to enlarge. If they don't enlarge, they don't obstruct. Is everybody clear, folks? So when it comes to GI, the postprandial pain is so important. And the abdominal diseases, postprandial pain. Very careful. Postprandial pain means not while eating, it's after eating. Is that clear, folks? Okay, postprandial pain. When SMA and aorta compress the third portion of duodenum. See, the next thing you need to know this, they added now. There was a question on NBME. They didn't ask what is superior mesenteric artery syndrome. They asked what part of the duodenum is exactly compressed. You see that? It's the third portion. Third portion has a special name. We call that transverse portion. Okay, so you need to know that. See, sometimes we know exactly what is superior mesenteric artery syndrome, but we just don't know the name of the third portion, then you lose the question. Okay, so it's a transverse portion is what it compresses, folks. Is everybody clear?
So
Okay.
when the third portion is supplied by the IMA.
Third portion is supplied by IMA. Yes, that's correct.
Okay.
Is it IMA? SMA?
No, third portion isn't supplied by the IMA. I thought third portion was in the. Oh. But if the SMA is inserting into the.
It's not inserting into it. Remember what I said? SMA is the big vessel. They give their small branches to supply third and fourth portions.
Okay.
They are not directly inserting. There's a tiny branches that goes. So that's not part of here, right? It's a big structure. Okay, so that's important. So that's the superior mesenteric artery syndrome. Is everybody clear, folks? Okay, now this is important. Typically occurs in condition associated with diminished mesenteric fat, low body weight when people have that. Is everybody clear, folks? Okay, so let's recap. Superior mesenteric artery syndrome is where superior mesenteric artery compressing the third portion of the duodenum after eating, folks, okay? Because they lost the fat. That's the idea here. Now, that's superior mesenteric artery syndrome. Since we are talking about postprandial pain, okay? Now, just to give an idea, since you have a space here, in GI, there's only two diseases you think postprandial pain. There's only two diseases. One is this one, superior mesenteric artery syndrome, where postprandial pain. Second disease is going to be chronic mesenteric ischemia. You should not be thinking any other diseases when a question says postprandial pain. Is everybody clear, folks? Because some people add a third disease, duodenal ulcer. How many people thought about that? Iman thought about it, right? There you go. Duodenal ulcer is pain when you don't eat. Does that make sense? Sorry, duodenal ulcer is when the pain comes when you don't eat. That's what exactly, yes. See, that doesn't mean it's postprandial. Does that make sense, folks? So the gastric ulcer and duodenal ulcer, gastric ulcer, pain while you eat. So as you are eating, it hurts. But duodenal ulcer, you didn't eat and it hurts. So there is no postprandial in there. Does that make sense, folks? So in GI, you only think these two diseases if your question says postprandial. Is everybody clear, folks? Because the reason I brought it specifically, anytime question comes postprandial, they always put a duodenal ulcer as an option. That's a wrong answer. Okay, so that postprandial mean I ate and now after it's been an hour. Whereas duodenal ulcer, I haven't ate at all and it hurts. Is everybody clear, folks? All
So
right.
basically, gastric ulcer is only when you eat.
When you
While
eat.
you eat, after eating, there's no pain.
No. Okay, so we're going to talk about, I'm going to get into duodenal ulcer. It's a big topic, but I have to mention it here to get the clinical importance. So that's your superior mesenteric artery syndrome. Is that clear, folks? All right. Now, similar to superior mesenteric artery, there is one more syndrome we call nutcracker syndrome, folks. What is that? It's similar to SMA syndrome, what we just talked about it, but it's a different structure. Here, compression of the left renal vein between superior mesenteric artery and aorta. Okay, so what did we say? Superior mesenteric artery syndrome, SMA compressing duodenum. The same SMA compresses the left renal vein we call nutcracker syndrome. That's simple. Okay, so if I tell you I have a patient, SMA is compressing, you should be asking me, what is it compressing? If it compresses the duodenum, SMA syndrome. If it compressed the left renal vein, Nutcracker syndrome. That's simple. Is that clear, folks? It's all about what structure it's compressing. That's what matters here, folks. Now, this is considered low yield than the superior mesenteric artery, but now you know both. Is that clear, folks? So when you read a question, just look at it. Is it left renal vein or duodenum? Now, when we talk about left renal vein, there is no postprandial because there's nothing associated with food intake. Is that clear, folks? Now, one of the interesting part, whenever they compress the left renal vein, they should have always left-sided varicocele. They have to have it. Can anybody tell me why? You could talk.
Maybe because left connects directly into the left testicular.
Continue properly.
Right renal vein continues to the IVC, but left directly continues to the
There you go.
testicular vein.
So a male has two testicular veins, right testicular vein, left testicular vein. Right testicular vein drains directly into IVC. Left testicular vein goes to the renal vein, left renal vein. So anytime you have a compression of left renal vein, you should automatically have left-sided varicocele. What is varicocele? Simply, your left testicular vein is dilated. Is that clear, folks? That's the idea, okay? So that's the key. So see, that's a good hint here. Instead of postprandial, when they have left-sided varicocele. Are we clear, folks? So that's that. And there's a question here, but I will bring it once we are done a little bit of more anatomy. Okay, so that can take care of this page. Is everybody clear, folks? All right. Now, we need to talk, before we get into celiac vein and stuff, let's go to portosystemic anastomosis. Let's go to this section. Now, when it comes to circulations, right, there is portal system, portal vein, and there's a systemic vein. Okay. Now, the word comes anastomosis. Anastomosis means there is a connection between vein to vein or artery to artery. Okay, that's called anastomosis. There's a communication between two different veins or two different arteries. Then we call it anastomosis, completely normal physiology. But if I have a connection between artery to vein, that is not anastomosis. That's called AV malformation or AV fistula. Because why? Artery is connecting to vein. That's not normal. We only connect either vein to vein or artery to artery. Is everybody clear, folks? So if it is opposite, artery connecting to vein, that's a fistula or malformation. That's pathology. Are we clear, folks? All right. So now we know that. So we are talking about vein to vein connection. That's what we call portosystemic anastomosis. So that means there is a connection between portal vein and systemic vein, folks. Okay. Now, for us to understand that, I'm just going to draw a little bit here. Okay. You don't have to draw, just here. Okay, so we have a structure here. Now, let me teach you first, I forgot about portal vein. Let's learn about portal vein. How does portal vein formed? Portal vein is one big vein. It's formed by joining three veins together. Okay, so what are those three veins together? We call it, so if you see, that's your spleen. Okay, so splenic vein, inferior mesenteric vein, and superior mesenteric vein. So structure 1, 2, 3. These three structures joined together, they form something here. This is your portal vein. So if I ask you, how do we form portal vein? Is by joining SMV, IMV, and splenic vein. Okay, all these three structures together, we call it portal vein. Even though splenic vein has nothing to do with the GI tract, but remember, embryologically, spleen came from foregut, isn't it, folks? So that's why all these three structures joined together form portal vein. So where does portal vein go? Portal vein drains into the liver. Is that clear, folks? So the portal vein is technically the most nutritious blood, because whatever we eat get reabsorbed in the intestines. That means all the nutrients are coming from SMV and IMV and everything to portal vein, and portal vein to the liver. Is everybody clear, folks? Are you guys following me so far? Now there's an important clinical, you could bring it here. So portal vein consists of SMV, IMV, and splenic vein. Let's go to this picture. Whatever we absorb in the midgut goes to SMV, SMV goes to portal vein. Agree? Whatever we absorb in the hindgut, IMV goes to portal vein. Makes sense. Whatever you absorb in the foregut goes directly to IVC, not to portal vein, which means anything you absorb in the foregut, it goes directly to the systemic blood. Is that clear, folks? So you should know anything you absorb in the foregut doesn't go to liver. It goes to the systemic blood directly. Now, do we even absorb anything in foregut? That's a question. The answer is most of the digestion starts in the stomach. Okay, so when we say digestion, mean first we need to mix the food with all the enzyme, isn't it, folks? And the absorption starts from the midgut. The two things that we absorb in the foregut is your water, 30% of water, and alcohol. That's why when people drink on an empty stomach, they get drunk faster. Why? Because the alcohol can be directly absorbed on the stomach. And when they absorb, where do they go? Systemic blood vessel. When it goes to systemic IVC, it can go to the brain faster. Is that clear, folks? Right? So that's why when you wake up early in the morning, if you drink a beer, it feels so good. No, you shouldn't do that. Now, the idea is it gets you drunk faster, right? So that's because it goes. Now, remember, if it goes to the liver, liver metabolizes everything, isn't it, folks? That's the idea, folks, okay? Just to give you, so foregut doesn't go to portal vein or liver. Are we good with that? All right. So now we did that. So let's go back here. So we know how portal vein is formed. Three structures joined together, it formed the portal vein. Perfect. Now, in human body, so let's say I'm drawing the portal vein in this structure. Okay, so I have to bring it here. So this is where the portal vein, and so I want you guys to imagine, because I cannot draw everything in the same picture. So that's your portal vein, at least you know that. Now here, there's a connection. This is the physiological anastomosis, where a tiny vein is communicating with lower esophageal veins. Here it's a lower esophageal veins. Remember, esophageal veins are part of systemic veins. Is that clear, folks? Okay, I'm only showing one example, okay? So this is a small, tiny connections. So normally what happens under physiological circumstances, there's a tiny blood flow goes this way. Either way, it doesn't matter, okay? So under physiology, it doesn't matter. But I want you to think, what if a patient develop liver cirrhosis? Liver cirrhosis means it's completely fibrotic. When they are completely fibrotic, we cannot drain anything from portal vein. Anything from portal vein cannot enter the liver. Agree? So when they cannot enter the liver, what's going to happen? The blood is going to start accumulating in the portal vein, and the blood pressure in the portal vein increases. Patient develop portal hypertension. Is everybody clear, folks? That's called portal hypertension. So what is portal hypertension? Simply the portal vein pressure is high because they are not able to get into the liver. Okay, they are not able to get into the liver. Once they cannot go into the liver, the pressure is high. Now what's going to happen? More blood is going to go this way because we have no other ways to go. Is that clear, folks? More blood is going to go to the lower esophageal area. Now the lower esophageal veins are receiving more blood than usual. Agree, folks? So the lower esophageal veins are going to be dilated. The dilated lower esophageal veins are called esophageal varices. Is that clear, folks? So whenever the patient comes with esophageal varices, you should know patient has portal hypertension. Is that clear, folks? Every time patient present the dilated lower esophageal veins, that means there is a portal hypertension. I don't know what's causing the portal hypertension, but I know patient has a portal hypertension. Is that clear, folks? Okay, so that's one anastomosis, right? If you look at this picture, look at this. This is that vein I was talking about. It's connecting to the lower esophageal area. So patient has esophageal varices. So esophageal varices is a sign of portal hypertension. Is everybody clear, folks? The second connection we have around the umbilicus. Okay, now what's going to happen? Around the umbilicus also, we're going to have a dilated vein because more blood is going there. We call that caput medusa. We call that caput medusa. The caput medusa is just a fancy word for dilated umbilical veins in the umbilical area. Is that clear, folks? Now the explanation why it's dilated, we are receiving more blood from the portal vein than usual due to portal hypertension. Third connection, it's in the rectum. Okay, so we should know first the normal connection. There's a normal connection in the esophagus. There's a normal connection in the umbilical area. There's a normal connection in the rectum. Now, when there is a portal hypertension, all those three locations is going to receive more blood than usual. Agree, folks? So what will be the symptom in the rectum? It's called anorectal varices, but I'm going to replace that with another name, internal hemorrhoids. Internal hemorrhoids. Okay, not external hemorrhoids, internal hemorrhoids. So, if a patient presents with esophageal varices, caput medusae, or internal hemorrhoids, it's an indication of portal hypertension. Agree? Okay, so that's
like
important.
all the three or just any one of them?
It depends on the severity. Okay, so sometimes patient can come with one symptom, sometimes with two, sometimes three, sometimes nothing. It's all individual basis. But you should know, as long as you have one hint, there is a portal hypertension.
And for internal hemorrhoids, the differential diagnosis, there are others as well, right?
There are different diseases. Yes, I'm going to get to that. Okay, there's an external hemorrhoids right there. Okay, we will talk about that in a moment, but I just want you guys to remember that. So I'm just going to write here in this space, esophageal varices, caput medusa, and internal hemorrhoids. All those three things suggest portal hypertension. Is everybody clear, folks? For a human to get portal hypertension, there's only two diseases mostly, folks. Okay, one is liver cirrhosis. One is liver cirrhosis. Second one, portal vein thrombosis. Portal vein thrombosis means there's a blood clot literally here, folks. Imagine if you have a blood clot here, it will block the blood flow, isn't it, folks? If it blocks the blood flow, the pressure will go high, right? So then they will have portal hypertension.
Sorry, I just had one question. When you say the esophageal varices, that when that happens, does it do anything to the esophagus sphincter or the peristalsis?
No, it doesn't do anything. It's just a dilated vein. That's all it is.
It's not going to interfere with any whatever the function esophagus has.
No, it doesn't interfere anything. Now remember, esophageal varices can become complicated. It can rupture and do. We will talk about that on the pathology when we do esophageal varices. So I'm only doing anatomy. Okay, so we will get to each of these diseases, but I'm just giving the big picture. Dilated vein in the esophageal area gets a name of varices. Varices means simply dilated vein. Internal hemorrhoids, it's simply the vein in the hemorrhoid area, it's dilated. Is that clear, folks? That's all it is, okay? So this is so important, okay? Now, if I am reading a question And if a question says esophageal varices or caput medusae or internal hemorrhoids, I know patient has liver cirrhosis or portal vein thrombosis. Is that clear, folks? Okay. Now, I could go one step ahead. One disease that's associated with portal vein thrombosis, PNH. What is that? Paroxysmal nocturnal hemoglobinuria. We mentioned that name at least 3 times, right, in the last 2 weeks. Okay. So we will talk about this in hematology, but that disease, paroxysmal nocturnal hemoglobinuria, has commonly associated with portal vein thrombosis. Okay. So that is key, folks. Is everybody clear here, folks? So we learn how portal veins are formed, and then we learn where the 3 anatomical anastomosis. So you should know the 3 anatomical anastomosis. One is in the lower esophageal area, one is in the umbilical area, other one is in the upper part of the rectum. Now, when there is the portal vein hypertension happens, all those 3 anastomosis area are going to get affected. They will have dilated vein. We get the name esophageal varices, caput medusae, internal hemorrhoids. Are we clear, folks? So that take care of this page. Any question to me in this page?
Just to verify, so you said a varus is a dilated vein. So a varicocele, like we mentioned before, was a dilated.
Varicocele is different, varices is different. But you could say varicocele is also dilated vein technically.
Oh, okay, thank you.
Varicocele is basically varicocele. Seal means there's a capsule or there's a kind of pouch that covering, but it's similar thing. It's all dilated vein. So clear, folks? Okay. Now, I know some student thinks we only call esophageal varices when they rupture. That's wrong. Esophageal varices can be ruptured or cannot, it didn't rupture yet. Is that clear, folks? As soon as you dilate the vein, it's called varices. That's all it is. Okay. So that take care of this section. Now we have to go find, not this one. Okay, let's go to this page. This is one of the high yield section here. There's so much question comes in here. We need to know this really well. Now, this particular section is only talking about celiac trunk, which means we know they supply foregut, isn't it, folks? So we are going more deep into celiac trunk, so pay attention. If you see here, folks, celiac trunk comes here and it gives you so many branches. So now it should make sense. It is a big branch, but they're going to give supply to the foregut, but they have their own tiny branches that comes off of, okay? So the first thing that we need to learn, common hepatic artery. Now you see that? That's your common hepatic artery. Let me color that a little bit. That's your common hepatic artery. Common hepatic artery comes and they divide it into proper hepatic and gastroduodenal. So I'm just going to connect like that. Okay. So common hepatic artery divides into proper hepatic and gastroduodenal artery. Now that's the most important. Now, if you don't remember proper hepatic, I'm okay, but you have to remember gastroduodenal artery. Now, if you see here, gastroduodenal artery is a branch of celiac trunk, technically, and it comes down. You see, it goes behind the duodenum. That's why it's kind of shadowed, that drawing. You see that, folks? It's going behind the duodenum, right? It goes behind the duodenum and coming down. Is everybody clear, folks? So for me to explain that, right? So let's see here. I'll use my hand. So imagine my hand is the duodenum. This is the anterior surface of the duodenum, and this is the posterior surface. My apple pen is the gastroduodenal artery. They are right behind. Does that make sense? It's right behind the posterior duodenal surface. Is that clear, folks? It's in the back, okay? It's in the back. Why do we need to know? There is a disease called duodenal ulcer. Sometime we could erode and causes damage to the posterior wall of the duodenum. When we damage the posterior wall of the duodenum, we could damage a blood vessel. Exam asks you what blood vessel is that? That's gastroduodenal artery. Is that clear, folks? That's gastroduodenal artery. If a patient is bleeding from duodenal ulcer, it's from gastroduodenal artery. Is everybody clear, folks? Why gastroduodenal artery? Because they are right behind the posterior wall. Is everybody clear, folks? It's behind, not anterior, but it's behind. Okay, so that's gastroduodenal artery. Now I'm going to write something here to make sure we understand this. So this is peptic ulcer. I'm just writing. Don't worry about what is peptic ulcer. Just write this down. Peptic ulcer is two types: gastric ulcer and duodenal ulcer. Now, if you are bleeding from duodenal ulcer, that's gastroduodenal artery. Is that clear, folks? If you are bleeding from duodenal ulcer, it's a gastroduodenal artery. This question always comes in the exam, and I'm going to tell you where a student goes wrong most of the time. Now, if you go back, on the other side, do you see this branch? Left gastric artery. Left gastric artery is this one, okay? Left gastric artery supplies the laser curvature of the stomach. You see that, folks? What did I tell you? When you have a gastric ulcer, the most common region is laser curvature. I mentioned it earlier, right? So if a patient has gastric ulcer, they bleed from left gastric artery. They bleed from left gastric artery. Now, where do you go wrong in the exam? When they give you the scenario of a peptic ulcer disease, you need to first pick which type of ulcer. If your ulcer is wrong, your blood vessel become wrong. Is that clear, folks? Let's say they are giving a scenario for gastric ulcer, but you think it's duodenum, then you're going to pick gastroduodenal artery. Okay, I have a question. I'm going to show it to you, but that's the most important here. Okay, folks, is everybody clear? The gastroduodenal artery and left gastric artery. Okay, so that's done here. Now, next one. Let me clean this up. Now, this is a splenic artery. You could see that splenic artery coming behind the spleen. What did we know about splenic artery? It's an endarterial organ. What does endarterial organ mean? Only one blood vessel that goes to spleen, that's splenic artery. There is no multiple supply. So splenic artery. Now look at this, guys. Splenic artery comes and they divide into small branches. One of the most important is short gastric arteries. Short gastric arteries. Now take a look here. This splenic artery divides this way, that goes to become a short gastric artery, and this one goes here to spleen. They also supply this area. Is that clear, folks? Now, for us to continue, we kind of need to know the name of these locations in the picture, folks, okay? The name of the locations, the stomach. We call this area cardiac region. Agree, folks? That's a cardiac region of the stomach. This is the fundus. This is the body. This is antrum. And that's a pyloric sphincter. Okay, that's the idea. Now, first task. What's the function of short gastric artery? They supply the fundus. Is that clear, folks? Short gastric artery supplies the fundus part of the stomach. Short gastric is a branch of splenic artery. Is everybody clear, folks? All right. Now, you could also see splenic artery has another branch, left gastroepiploic. Highlight that. Left gastroepiploic. So I could technically say splenic artery gives two side branches. One is a short gastric, one is left gastroepiploic. Clear, folks? Okay. Now, what does left gastroepiploic do? It comes and supply the body of the stomach. Agree, folks? Now, what else I do? Look at the anastomosis. They join with right gastroepiploic. Easy. Left gastroepiploic join with right gastroepiploic. That's an anatomical anastomosis because artery to artery. Is that clear, folks? So right gastroepiploic connects with left gastro. So they have a connection. They have a connection. The one question that comes, 9 out of 10 students get this wrong. And some of you will get it wrong even after I explain, so careful. Okay. Now, if there is a block in the splenic artery, let's say there's an embolism or thrombus, something blocked completely. Your splenic artery is blocked 100%. Is that clear, folks? Which part of the stomach will die? Type it up. Don't say it, type it up. Which part of the stomach will die? If you have a 100% blockade of the splenic artery, which part of the stomach dies? Okay. Now, I could give you 2 options. Fundus is on the top or body. Those are the 2 answers. What's the answer? Fundus. Why is that? Let me explain. When you block the splenic artery, short gastric never get any blood flow. Is that clear, folks? But when you block splenic artery, your left gastroepiploic also don't get it. I agree with that. But right gastroepiploic give you collateral circulation. You see that here. Because it has a collateral circulation, body will not die because your right will bring more blood and help. But whereas fundus, there is no other collateral circulation. One and only artery is a short gastric. Is that clear, folks? Okay. So is that clear, folks? So that's where the confusion comes, okay? So when there's a blockage to splenic artery, short gastric has no anastomosis, so there is no other way to survive. But on the bottom, it's okay, because even if there is no blood, your right gastroepiploid can help. Is that clear, folks? So you could get 2 questions on the step 1. They could ask you what part it dies, or they could ask you how come the body don't die. The answer is right gastroepiploid. Does that make sense, folks? So you should know both options, okay? So that's the blood vessel in this area, folks, okay? Now, all right. Any question in here in this section? All right, so that's important. Those 3 blood vessels, folks, left gastric artery, gastroduodenal artery, and short gastric artery, folks. You cannot miss this. This is so important, folks, okay? That's the idea. Now, blocking is one option, embolism. Or you could have some mass or some cancer that happens in the stomach and compress that also, okay? So that's that. So that take care of it. So let's pull up some question of what we have done so far. Yeah, let's see.
I had a question.
Sure.
So the right gastroepiploid does not supply the entire fundus. It only supply half of it, technically. Right?
Not fundus. Why are we bringing fundus into that?
No, I mean, because you know how they have the connection, the anastomosis on the bottom.
They only supply
So,
the body area. They do not supply fundus.
but even with the anastomosis, not even like the half or a little bit above like that.
No.
Okay. That's what I knew it was fundus, but I'm thinking, why isn't it, connecting it? So
You can create structures the way you want. I want the diagnosis and the answer. 14-year-old girl is evaluated in the burn unit due to nausea and recurrent bilious vomiting occurring over the past 4 hours. 12 days ago, the patient was admitted to the burn unit after she was in a house fire. Examination on admission showed deep and superficial partial thickness burn covering 40% of the body. That's a big one. And the patient has been receiving IV fluids, analgesic, nutritional support, and wound care with slow improvement. Temperature, she has fever. Remember we said 100.4 and above is fever, okay? She has fever because why? Burn patients, one of the most common complication is infection, okay? So that's that. Finding consistent with those previous days, okay? Physical exam shows mild diaphoresis and mild abdominal distension. Multiple wound and blood cultures are taken since the admission is negative. CT scan of the abdomen with IV contrast demonstrates significant reduction of the angle between the superior mesenteric artery and aorta. Now remember folks, all these are scenario, but nothing helps until you get to this line. This is where the actual hint for the question coming. Superior mesenteric artery angle is reduced, okay? With compressing and intervening portion of the GI tract. Impingement of which of the following structure? Now, first, what's the diagnosis? Superior mesenteric artery syndrome. Did we get that? If we get superior mesenteric artery, then the answer should be which part? Third portion of the duodenum. It's called transverse portion of the duodenum, right? That's transverse. You see here, folks, in this question, they didn't actually use the word postprandial because if you use it, it becomes too easy. It's become too obvious, but they are changing the scenario, okay? But you still know that's the answer here. Now, let's say, did they even bring the renal part here? No. So you have no even confusion with Nutcracker syndrome here, okay? So that's that. I like this picture. Look at that. That's exactly how the superior mesenteric artery goes between these two. And there is a fat which is not shown in this picture. All good? All right, next question. I want the diagnosis, okay. Well, I guess they show it, okay. A 75-year-old man is brought to the emergency department due to acute onset of profuse vomiting of large amount of bright red blood. He has had intermittent, dull epigastric pain for the last 3 months. Medical history is significant for COPD and multiple exacerbation and lumbar stenosis. The patient has smoked 1 pack of cigarettes daily for 40 years. The blood pressure is low. Examination shows epigastric tenderness. The patient dies. See, until this, I still don't know the diagnosis because it's very vague. It could be so many things, okay? So the patient dies an hour after admission, and autopsy shows deep peptic ulcer localized proximally on the laser curvature of the stomach. That's the hint here, right? This is an ulcer in the stomach in the laser curvature, so most likely gastric ulcer. Is that clear, folks? That should be gastric ulcer. And they should be bleeding because you see the blood pressure. All I know is it's bleeding from there. Now here, your answer should be between these two. You should be fighting between B and D. Does that make sense, folks? If you get duodenal ulcer, you go for B. If you get gastric ulcer, the answer is left gastric. Is that clear, folks? All right. So that's the idea here. Now you see, it's the same picture, what you learn. That's a short gastric artery that supply the fundus. Always keep an eye on that. All good with this question? Okay. Right, let's see what's happening here. 56-year-old man comes to the physician complaining of early satiety. I think we mentioned this earlier before, but again, anytime you read a question and if you see early satiety, that means something is not right in the stomach. Okay, it's mostly a stomach cancer or gastric cancer, or there is a mass that's compressing the stomach. Okay, so that means, when you see that line, you should know some pathology involving stomach. Vague epigastric pain for the last 4 months. He has a 36-pack year smoking history and admits to drinking alcohol daily for the last 15 years. On physical exam, the patient appears thin and cahetic. See, that's suspicious even for malignancy. Is that clear, folks? That almost confirms. Palpation of the abdomen reveals splenomegaly. Why splenomegaly here? When there is a mass developing in the stomach, it can block the splenic vein, not splenic artery, splenic vein. When they block the splenic vein, the blood cannot drain from spleen, so the spleen started enlarging. Is that clear, folks? Okay. Abdominal CT scan shows a large irregular mass extending posteriorly from the greater curvature of the stomach, impinging of the splenic artery and vein. See, they already give you that. Okay, now tissues supplied by which of the following arteries would most likely be affected by compression of the splenic artery? They are simply asking this question: what's the function of splenic artery and its branches? So if you block splenic artery, which blood vessels get affected? You should know two. One is a short gastric, other one is left gastroepiploic, isn't it, folks? But then you have no problem with left gastroepiploic, because right supplies collateral circulation, isn't it? So you rule out this, you rule out this, you rule out the short gastric artery, folks. That's all it is, okay? Short gastric artery, because that has no anastomosis. Now look at that, the same picture. If you have a mass here, short gastric don't get blood, but this one has a collateral circulation. In the exam, I was told they put a similar question. Instead of name of the blood vessel, they put the parts of the stomach. The answer will be fundus. Is that clear, folks? So very careful. And all right, last one. Let's try this. Right, I'm seeing all the alphabetics here. All right, let's go. Now, 64-year-old man comes to the emergency department after an episode of hematemesis. That means blood coming from GI tract, from mouth. Okay. He also reports dark stool and abdominal pain for the past several days. The patient has a history of chronic pancreatitis. Abdominal examination shows epigastric tenderness to palpation. Rectal exam is notable for black guaic-positive feces. Upper gastroendoscopy reveals bleeding spot within the cluster of enlarged tortuous vein in the gastric fundus. So there is a problem with the gastric fundus blood vessels. Does that make sense, folks? Now you should know when they talk about the tortuous part, it's a vein. Even though the question says here vein, only veins can curly because of the weak structure. Artery will never do that. Okay. The rest of the stomach and esophagus appears normal. Increased pressure in which of the following vascular structure is most likely cause this patient's conditions? What's happening here? So why do you think the fundus blood vessels are tortuous? That means these veins are not able to drain. Does that make sense, folks? When do you think you cannot drain? When splenic vein is obstructed. Whenever the splenic vein is obstructed, the blood from the fundus area cannot drain. Does that make sense, folks? So which blood vessel is that? Short gastric veins. Is that clear, folks? Now, some people picked superior mesenteric vein. We are not talking about the midgut here. We are still in the foregut. Is that clear, folks? They are specifically saying gastric fundus. Which vein supply the gastric fundus? Short gastric vein. The only time short gastric vein can torture when the pressure increases. When do you think the pressure increases? When the splenic vein is compressed, so no venous drainage. Is that clear, folks? All right. I know this is a little tricky. Look at this picture. Beautiful question. Those are the veins that torture us because there's a block. Here, the patient has splenic vein thrombosis. There's something blocking the splenic vein. It could be thrombosis or it could be a malignancy. Is that clear, folks? So that's the idea. Now, for you to even pick this answer, right? So you should know it's a fundus. That's a short gastric vein. The only time you could increase the pressure of short gastric vein, then when there's a blockage of splenic vein. Nothing else here would increase that. Agree, folks? All right. That's see, left gastric vein, that's this side. It has nothing to do with the fundus. That's laser curvature. Okay. So we are only talking about fundus completely opposite side here, folks. Okay. That's the idea. All right. So that's that question. All right. Let's go back to the page 375. Okay. Now, this is very important, folks. Okay. There is something called pectinate line. Okay. There is something called pectinate line, folks. Okay. Now, you should remember pectinate line is an imaginary line. It's not present in the patient. Don't go look for it. Okay. Now, pectinate is an imaginary line. So what does that mean? There is something called above pectinate line and below pectinate line, right? So the best way to explain, if this is the anus area, whatever the area you can touch with your finger without inserting, it's called below pectinate line. Okay. So that's your below pectinate line. Now, for us to touch a patient's above pectinate line, you literally have to do digital rectal exam. Our fingers has to go inside. Does that make sense, folks? So the external part is called below pectinate line. Internal part is called above pectinate line. Is everybody clear, folks? That is so important for you to differentiate first, below pectinate line and above pectinate line. Okay, so that's the idea. Okay, now, first thing to learn, below pectinate line, I said you could literally touch with your finger without a digital rectal exam, which means it's part of the skin. Is that clear, folks? That means the epithelium is going to be squamous epithelium. That's important. So below pectinate line has squamous epithelium. Above pectinate line has columnar epithelium. Because why? It's inside. So they have secretory part, they have it. Now, why do we need to know this? If you have a cancer above pectinate line, it's columnar cell, so it has to be adenocarcinoma. If you have a cancer below pectinate line, that's a squamous cell, so it's squamous cell carcinoma. You see that? Two different cancers, one above and one below. Is everybody clear, folks? Okay. So that's the first one. Anybody has a question with this tissue part? Now, second, below pectinate line is sensory nerve, which means you could feel everything. Above pectinate line, autonomic nervous system, which means no sensation. Okay, now look at this one, folks. Somatic innervation. Somatic means you could feel it. What nerve gives the sensation? Pudendal nerve. You need to know that. Pudendal nerve. Above, it's visceral innervation, which means you cannot feel the pain, or we cannot feel anything above pectinate line. Now, above pectinate line, you have arterial system, superior rectal artery and everything, but that goes to IMA, inferior mesenteric artery. If it goes to inferior mesenteric artery, I mean, it doesn't go to, it get blood supply from inferior mesenteric artery, okay? Not this one, okay. Talk about the vein. Superior rectal vein, inferior mesenteric vein, which means it goes to portal vein. Is that clear, folks? Anything above pectinate line will go to portal vein. Are we clear with that? But look at the below pectinate line. It's very important. It actually goes to IVC, not liver. So below pectinate line, we send it to systemic blood vessels. Is that clear, folks? Now, why do we need to know? The best example with the kids' pediatric cases. When a kid have newborn or infant or toddler has a fever, let's say when the temperature goes more than 104, you know the kid is going to get seizures soon, right? So what do? We have to bring the temperature down. What do? We put a capsule in their rectum, in the butt, isn't it, folks? We insert a pill right there. Why do we put a pill right there? Why not give Motrin or Tylenol orally? If you give medication orally, it's going to go to the liver. Liver will metabolize, and it takes time to get to the blood. Is that clear, folks? But if I put it in the butt, it will go directly into IVC, IVC to systemic blood vessel. The temperature can drop faster. Does that make sense, folks? So the reason we put the capsule in the rectal area is to get the medication faster to the systemic blood. Is everybody clear, folks? Sometimes parents make a mistake. They put a capsule and they push it way inside. If they push it inside and if the capsule goes a little more inside, it's still going to go to the liver. Does that make sense, folks? So the best way to do it, when you put a capsule, 2/3 stays inside, 1/3 has to protrude outside. That's how we know it's at the right location. Is that clear, folks? So just a scenario to give you the importance of below pectinate line and above pectinate line. Is that clear, folks? The last thing, anytime you have a dilated vein above pectinate line, we call that internal hemorrhoids. Why do we have internal hemorrhoids? That's because you have portal hypertension. Is everybody clear, folks? Because that's portal vein, isn't it? Now, when you go below pectinate line, that's external hemorrhoids. That's external hemorrhoids. How do you differentiate internal versus external? The first and easy, external is somatic. That means it hurts so badly. People can feel the pain of external hemorrhoids. They won't even sit on the chair. Why? When they sit, it touches it, so it hurts. Does that make sense, folks? Whereas internal hemorrhoids, autonomic nervous system, which means there is no pain. They won't even know that they have internal hemorrhoids. In another word, the only way people can tell they have internal hemorrhoids, when they bleed, all of a sudden they see blood coming out. That's the only way they know that. Is that clear, folks? So internal hemorrhoids, painless. External hemorrhoids, painful. It shouldn't be a big confusion in the clinic. When you ask to sit down, sit down on the table, they will sit at the edge. That should tell you it's an external hemorrhoids, because if they sit back, it hurts. Okay, and also, if it is external hemorrhoids, I'm not too worried, because it's mostly constipation is the issue. So we give a stool softener and stuff, it will get better. But if a patient has internal hemorrhoids, just for clinical purpose, I get worried because that's a suggestion of portal hypertension, isn't it, folks? So every time patient has internal hemorrhoids, we get worried and we have to send it to hepatologist because that's something big happening inside. Stool softener, those won't help. Okay, so that's a difference between internal hemorrhoids and external hemorrhoids. Is everybody clear, folks? Whereas external, again, it's a constipation. Simple. That's a problem here, folks. Okay, we tell them to eat more fiber food, more broccoli, and then stool softener. That's what it is basically. But internal is a different issue. Okay. Now, again, the definition of hemorrhoids, whether it's internal or external, it's a dilated vein. If it is located above pectinate line, we call it internal. If it is below pectinate line, external. Are we clear, folks? So that's a venous problem, okay? Hemorrhoids is a veins problem. Agree? Because we have one more disease. We call that anal fissure. Because sometimes it's very difficult for people to differentiate anal fissure from external hemorrhoids because both are painful, extremely painful. I want you guys to remember, anal fissure, it's basically a tear, okay? It's a tear in the mucosa. It's a tear in the mucosa, nothing to do with the veins. It's a tear in the mucosa, nothing to do with the veins, folks, okay? It's below the pectinate line. They usually say blood on the toilet paper because it's tear and it's when they wipe, bleeding happens, folks, okay? Located, you should know first, it's a mucosal problem, but then most commonly the posterior midline. That's what kind of tear is because that has the poorly supplied area. The blood vessel is less in there. So that's a poorly oxygenated area. So that means it's predisposed to tear. Is that clear, folks? Yeah. What is the reason? It's simply low fiber diet and constipation. So the best way to think, when the stool caliber is thick, we see it in the kids most commonly. If the stool caliber is thick, it overstretches the mucosa and it tears. And 3 days, it heals, new epithelium regenerate, they will be fine, unless if it is a big. Sometimes I've seen one patient in our clinicals almost 10 years ago. The patient came, it's a big anal fissure, they have to go through a surgery. Those are more common in homosexuals, okay? Now that requires a surgery, big tear, folks, because remember, that's also sphincter. They lose the integrity of the sphincter too, right? So just remember, anal fissure, it's a mucosa problem. Hemorrhoids, it's a veins problem. That's a basic differentiation. Is everybody clear with that, folks? So you see, there's so much you could differentiate internal and external, or above pectinate and below pectinate line. Is that clear, folks?
Is there any way continuous anal fissure can lead to external hemorrhoids?
Say it again.
Is there any way the continuous anal fissure can lead to external hemorrhoids?
Because what happens is when people have anal fissure, if it is mild, it heals automatically in 2-3 days. If it doesn't, it's a big one. If it is tearing more, what it does is it can rupture some veins, okay? Now, when they rupture, you are just bleeding, but in order to call it external hemorrhoids, they have to have a dilated vein in the first place. So here they didn't have a dilated vein, so we cannot call external hemorrhoids, okay? So basically it's a complicated anal fissure, but patient don't have external hemorrhoids. Is that clear, folks? Okay, now can a person get both at the same time? Yes, they can. If somebody has a constipation, they could get external hemorrhoids and anal fissure. Buy one, get one free at that point. But it's their constipation issue, folks, okay? So we cannot do anything on that. But that's the two diseases. They get both together, but one cannot lead the other one. Is that clear, folks? All right. Now, that's the pectinate line. That take care of that, folks. All right, go take a 10 minutes break, come back, and we're going to start with this page, one of the most interesting page, folks, okay? All right.
Doctor, can you repeat really quickly? You said the rule for the pill is 2/3 in, 1/3 out?
Yeah, so what happens is when you put a capsule in the rectum for the babies, you don't want to push it too much inside. If you push it too much inside, you are pushing it to above pectinate line, still it's going to go to the liver. You don't want that.
Okay, gotcha. Thank you so much.
No problem. Hi, Manikya.
Hello, sir.
How did the study go over the week?
It went well, but then I was not able to cover GI properly because I didn't know what sources
Okay,
or
got it.
what to
But
do.
endocrine and respiratory is good?
Yes.
Okay. All right.
I just have a doubt. Like, remember, like, the suppositories that you use for the fishes or anything. So, do you also place that 1/3 and 2/3?
Yeah, suppository and capsule,
Okay.
both are same. I use the
Okay.
word capsule, but it's suppository. It's the same thing. Yeah.
Okay.
All right.